Hello, thank you all so much for having me here. I really appreciate this. I always have to say I'm always a touch intimidated when I'm in a room full of surgeons, and I'm the only non-proceduralist here, to be totally honest. I'm going to try my best to answer this question because obviously there's a lot of nuance behind this, and I only have 30 minutes, so I definitely won't be able to get into the true weeds of this actual conversation, but we will do our best. First off, disclosures, I have none to report. My learning objectives. So I have a few learning objectives. I want to go over a couple of different risk assessment tools that all of you guys would be able to access and utilize to see how sort of medically stable is a patient. And most of the time we're talking about from a cardiac standpoint prior to doing an intervention. One of the other things that we always have to assess prior to an intervention is what is the actual patient's functional capacity. So I'm going to discuss a few tools that you guys can figure that out too as well. And then recognize, is a patient actually medically optimized prior to going to an intervention? So what does medically stable mean? You know, that it's obviously an extraordinarily broad term as to what medically stable could potentially see. I think our number one, of course, is cardiac, right? Because that's obviously going to be one of their highest mortality risks when somebody's going into a procedure. What's becoming a bit more popular, definitely seeing a lot more, is people also looking from a pulmonary standpoint too as well, because of course we are seeing patients who have much more advanced emphysema, COPD, et cetera, who are requiring some sort of interventions. There's also just general well-being, and in this list obviously can go on and on. We're seeing a lot more cirrhotic patients. Those patients also need special sort of care and monitoring pre and post intervention, et cetera. So just for the sake of time, obviously I don't have a ton of it, which I still appreciate the minutes that you guys are giving me. We're gonna first really just focus on cardiac, since again, I think that is the highest stakes. So we're gonna follow a very basic, simple algorithm to sort of see, is this patient ready to go to a procedure, or what do we have to do ahead of time? So the very first step, when you guys call us for risk assessment, the first thing we ask is this intervention life-saving or limb-saving? And obviously limb-saving is definitely something that you guys have to deal with quite a bit. And that means like emergent limb-saving, okay? So that would be potentially somebody who obviously has an ischemic limb that is acute, that needs intervention immediately, or potentially horrible necrotizing fasciitis, and they need immediate debridement, et cetera. So if this is life-saving or emergent type of a surgery, don't even call us, actually. They need to go to the OR, right? So they have to go straight to the OR. There's nothing I can do in the meantime that's gonna optimize them or make them any less of a risk, unfortunately. So they are considered to be elevated risk no matter what. But obviously here, the benefits are gonna likely outweigh the risks. They need to go to the operating room. Now, if this is not an emergent surgery, we go on to the next step. So the next step, and this one seems intuitive, but you want to make sure you ask this question, is this patient having an MI? So if they are coming in, they may have something going on, you know, with their foot, again, something along the lines of some limb ischemia, et cetera. But if they're actively having an MI, we obviously have to address that first. So that would be our acute coronary syndrome. So if they are having that, clearly call your cardiology colleagues. They need to actually treat that acute coronary syndrome as per the guidelines. However, if they're not, this is kind of where me as an internist really comes into the picture. And this is where I start figuring out, okay, what is their risk for having a major acute coronary event? So how do we assess risk? There are numerous tools that are out there. And so again, for the sake of time, I'm just gonna focus on the two most popular and the two that have been the most validated specifically. Is anybody here familiar with the ACS and SQIP, or NSQIP is what we call it, just because it's a lot easier? Anyone here familiar? Yeah, so this is actually surgical data, which is fantastic. It's a quality improvement project that has been going on for years, essentially, where they've been able to collate a whole bunch of data to kind of figure out what people's risks are. This is a very involved tool, so we will get to it. I will say it's not one that I use very frequently. I'm a little bit simplistic too as well. I like what's easy, kind of easy to sort of even memorize and kind of pull up. So I use more commonly the Revised Cardiac Risk Index, but I am going to discuss both of these. So here is an example, hopefully you guys can see this, I know some are kind of way in the back there, of what does the ACS NSQIP actually involve. Just so you know, in my references, I do have the link to this website, but if you ever want to go to it, it's very simple just to Google this, like just to Google this calculator tool, it'll come up immediately. You have to show that you're not a robot, et cetera, along those lines, but it's pretty easy to get in there. So it's very involved though. So this is quite an involved survey. So as you can see, there's the procedure, that you would have here. So you would actually have to enter the procedure name, or probably even better would be the coding number. So if you can actually come up with a CPT coding number, it's very accurate that way that you can put that in. The next thing is you would talk about whether or not there are any other surgical options or non-operative options, et cetera. So you click that. And then it actually goes into several different things. So it's going to ask your age group, the gender of the patient, their functional status, is this emergent or not, the class of the status. So this is the American Society of Anesthesiologists class. So this is going to say, like, do they have no systemic disease up to a level 5, which is very severe systemic disease? Are they on steroid use for any sort of chronic condition? Have they had ascites within the past 30 days? Have they been septic in the past 2 days? Are they on a ventilator? Do they have metastatic cancer? Are they diabetic? Hypertensive, actually on medication? Have they been in an exacerbation of heart failure within the past 30 days? Do they have a history of dyspnea? Are they a smoker? At least within the past year, have they been an active smoker? Do they have a history of severe COPD? Are they on dialysis? Do they have an acute kidney injury? And then, of course, you can do the BMI calculation. So that's a lot of demographics, obviously. But it does come with quite a bit of yield. So this is what you see afterwards. So it really gives you a ton of information and ideas that you can actually discuss with your patients in regards to, sorry, I just realized those are like all on my face. So, to kind of discuss the risks versus benefits with the patients in of itself. So here I just kind of did a very, kind of probably somebody that you'd see pretty frequently. So the surgery I chose was going to be a amputation, transmetatarsal amputation. The risk factors I put in, I made it a little bit of a more older patient, so between 75 to 84 years. I said that they actually had severe systemic disease, because I would imagine, right, most patients, unfortunately, who need this type of amputation probably is going to have pretty severe systemic disease. Said obviously that they're diabetic and they're actually insulin dependent, and they also have hypertension. So as you can see, gives you a whole range of whether or not they have like a serious complication, and gives the patient's risk versus the average risk. And it goes more than just the major acute coronary events. So here's the cardiac complications. So for this particular patient, it's in the red zone. So it is somebody who would be above average for having a cardiac complication perioperatively. But it's a 2% versus 2.8%. So I'm not sure, as you guys as independent practitioners, how much of a risk that really is for you. You could see the largest risk, though, is that this patient very likely is not going to be able to go home post-operatively. They're probably going to need some sort of advanced skilled nursing facility or potentially inpatient rehab. So this is a wonderful tool that gives you a whole bunch of information, obviously. For me, it's not quite as clear-cut, I would say, in regards to the exact risk. Some of these, you can get into the statistical game, like, yes, absolutely, your risk is higher, but we are talking the difference of, 0.8%. Now, granted, obviously, talking about death, that 0.8% may be enough for somebody to say, no, I don't want this procedure, but, lots of great information. The times that I use this, it may be on somebody who really says, when I do my other risk calculator, says they're good to go to surgery, but I'm just worried maybe about the frailty of the patient, and I want the patient to understand things such as you're actually going to have a pretty increased risk for maybe needing to be on a ventilator afterwards, or you may have to go to the skilled nursing facility, and if that's something that you're not interested in, we may need to discuss a little bit further. So excellent tool, highly recommend it if you are wanting a lot of information to kind of discuss with your patients. Now, the revised cardiac risk index, like I said, this one's a little bit easier, and it's one that you can actually memorize too. Now, mind you, this is also readily available in your med calculator. I'm sure you guys are familiar with MedCalc application that you can use for a whole bunch of different calculations. So it is readily available there, and it's fantastic. So it's really just looking at 6 major risk factors, essentially. I apologize, I was just recently in Canada, so I think I had Canada on my mind when I stole this lovely picture here. I should say I borrowed it. I do give credit, obviously, for it. So there are some like Canadian issues here, but we'll discuss it either way. So the revised cardiac risk index, again, it's 6 things specifically that we look at for our patients. So do they have a history of ischemic heart disease? That's going to give them a point. Do they have a history of heart failure? Do they have a history of TIA or stroke ever in the past? Are they on insulin for their diabetes? So they could be diabetic, but if they're not on insulin, then they don't necessarily have to have a point there. Do they have chronic kidney disease? And this creatinine here, I know it's the weird Canadian numbers, but here in America, that would be equivalent to a creatinine greater than 2. So if they have chronic kidney disease with creatinine greater than 2, that's going to give you a point. or is this a high-risk surgery? We'll talk a little bit more about high-risk surgery in the next slide. But high-risk surgery in general, when you really think about it, is going to be vascular, open vascular, so not endovascular necessarily, but open vascular surgeries, particularly intra-abdominal or intra-inguinal is going to be some of our highest risk surgeries. But amputations also can count too as well. So you count up all their different points that they receive. And so really what we look at is if somebody has a score of 0, they're extraordinarily low risk. Score of 1, still low risk-ish. Above 1, that's when we're going to actually start saying they're at elevated risk. So that's something that has actually changed into the revised cardiac risk index. Before they used to say low risk, intermediate risk, high risk. It's now just low risk and elevated risk, essentially, along those lines. And these can give you some exact percentages of what are their chances of having a myocardial infarction, cardiac arrest, or death 30 days after surgery. So really looking for anything less 1 and under, usually pretty good to go. And I guess that's another thing as a sidebar. I think what Dr. Steinberg was even saying earlier was a lot of our patients are actually okay to go to surgery. I think a lot of the times we think, oh my gosh, they're so ill, there's no way. You'll be surprised on how many patients they say, yep, they're good to go. No further testing is necessary. So just kind of giving you an idea again of the stratification of the risk of surgery. So you have our low-risk surgeries. This would be bedside wound debridement. Obviously, nothing that's requiring any sort of anesthesia or anything else like along those lines would be considered low risk. Intermediate risk surgeries, that's actually what I see the most of, honestly. I would say about 25% of my clinical practice is perioperative medicine. I am an academic hospitalist, so I do honestly see mostly post-operative, but we do some preoperative evaluations too as well. And I see mostly hip and knee replacements, so that's going to be my classic intermediate risk surgery. High risk surgery, as I already talked about, is going to be a lot of our vascular surgeries specifically, so very appropriate for this here conference in of itself. And what you guys would actually see here would be, again, the open limb revascularization, amputation, or thromboembolectomy. That would also be considered a high-risk surgery. So with the revised cardiac risk index, you get a point for that. All right, so now we're kind of on to that next step. So what is their risk? So we've kind of used one of our tools to try to figure out exactly what is the risk for this patient. If they are actually low risk, so if their cardiac risk, revised cardiac risk index is 0 or 1, they can go straight to surgery. You actually don't have to worry about doing anything further. They're off to surgery. If they're elevated risk, so this is again 2 or higher on the RCRI, now we have to figure out what is their functional status. So functional status, we actually look at your metabolic equivalence. So that's how we want to figure out, is this patient actually physically fit enough to be able to handle surgery, essentially along those lines, okay? So there are multiple different ways, again, that you can actually try to assess functional status. When I was a medical student and a resident, how we mostly did it was by asking very simplistic questions to our patients. We would ask questions like along the lines of, can you climb 2 flights of stairs holding your groceries? Do you become short of breath, or do you have any sort of chest pain? And if they said no, we'd be like, all right, that's equivalent to a METSA 4, you're good to go. Or we may even ask, if they don't have stairs, can you walk 2 city blocks? Cities blocks are different, so that's not a very scientific measurement. Like, I'm actually from Chicago originally. Our city blocks are way bigger than the city blocks here in New York. So that's not very accurate, but we would ask those questions anyway. Can you walk 2 city blocks without becoming dyspneic, without having any sort of chest pain? And if they said yes, okay, you're good to go. There has been updates though, and this is extraordinarily well validated, very well studied, and Duke has come through on this one. So we have the Duke Activity Status Index, or the DASI is how I say it, because obviously that's a lot easier. So again, this is an extraordinarily validated tool. We'll go into it in a little bit, but it helps us to be able to calculate METs much more accurately. In some of the studies they did was actually measuring oxygen consumption and seeing how well this patient is in regards to being physically fit. Now, this other one here is interesting because, like I said, I've become a huge fan of the DASI in the past several years. But interestingly, actually just recently in Switzerland just did a study asking about those 2 flights of stairs again and asking if somebody can climb those 2 flights of stairs. And they actually validated that and saying, hey, this actually looks pretty good. My argument is I don't think our patient population, just as we were discussing in the last lecture, really is reflective of Switzerland's population. I don't think they have quite the same issues there as we do, unfortunately, here. So this is kind of going over the dossier. So this is something you cannot memorize, so I do apologize. It's not super duper simplistic like the RCRI is. But again, it is readily available on your MedCalc application, so it's very easy to access. And it does, MedCalc's wonderful because it does all the calculations for you, because there's actually math involved in this, and none of us want to do math on our, during, and well, some of you guys might do, but me, no, thank you. I want a calculator to do it for me. But this is a much more extensive questionnaire, but in all honesty, it takes you still 30 seconds, to ask your patients this questionnaire to see what their functional capacity is. So as you can see, it's asking very basic things. Can you take care of yourself? This is your very basics activities of daily living. Can they dress themselves? Can they bathe themselves? Can they go to the restroom on their own? And then you also ask, can you walk indoors, just around your house in general? Can you walk a block or two on level ground? So those are old historical questions coming back in, but it's not them by themselves. Can you climb a flight of stairs or walk up a hill? Can you run a short distance? Do light work around the house? That would be dusting, washing dishes. Can you do moderate work around the house? Vacuuming, sweeping floors, carrying the groceries. Heavy work would be scrubbing floors, lifting, moving heavy furniture. Can you do yard work such as raking leaves, weeding, pushing a power mower? Can you have sexual relations? Can you participate in moderate recreational activities, so golf, bowling, dancing, etc., or even strenuous sports such as swimming, tennis, football? I love this particular questionnaire because, especially for you all, right? Some people may have mobility limitations, and that really affects our previous questions, right? Like they might be able to climb a flight of stairs without becoming short of breath, but they just physically can't do it because they have, non-weight-bearing status potentially on one of their limbs, et cetera. Whereas there's plenty of activities here that you don't necessarily need to be fully weight-bearing that you can actually assess, and that would be able to help calculate the METs. So they add up all these scores, they do some math, and again, it calculates the METs, and our goal here is a METs of 4 or greater. So now we've calculated the patient's METs. Are they greater than 4? So this is somebody who on the RCRI would be considered elevated risk. That's how we've gotten to this step, where we're calculating the METs. If they're greater than 4, they're good. They're off to surgery. So again, that really captures a lot of your patients, right? That they don't necessarily need a ton of testing prior to it. They are okay to go to surgery. Now, if they're not greater than 4, this is where the deep discussions start, okay? So this is, are they medically optimized? Or we have to start discussing, will the benefits of the surgery outweigh the risks? So is this patient medically optimized? So what are the patient's comorbidities? That's really, as me as an internist, part of my whole risk assessment is not just doing these basic algorithms. I'm gonna be taking a full history and doing a full physical, and also doing a full medicine reconciliation too as well. So these are obviously just some comorbidities, but these are probably the ones, again, that we see very frequently. So do they have a history of coronary artery disease? Do they have diabetes? Do they have heart failure? Are they on dialysis? And these questions are they on all the appropriate treatments, for these particular disorders? For coronary artery disease, are they on a statin, like one of our favorite meds in internal medicine? Are they on an antiplatelet if they need to be on an antiplatelet? Diabetes, what is their A1C? How well controlled are they in regards to their A1C? Heart failure, there's a slew of meds now for guideline-directed medical therapy, particularly for reduced ejection fraction heart failure. And then with chronic kidney disease and end stage, are they euvolemic? Are they have been dialyzed appropriately? Are they at the dry weight? Are their electrolytes all stable? So kind of going further then, if they are medically optimized, so for example, if I have a patient, right, who has known coronary artery disease, they may be asymptomatic from it, but they are considered to be elevated risk when we have gone through that whole RCRI type process. But they unfortunately may not be physically fit, so they can't get a METs greater than 4. So if they are medically optimized from the coronary artery disease standpoint, meaning they're not having any major symptoms of angina at this point or escalating symptoms of angina, they're already on their statin, they're already on their antiplatelet therapy. If they have had a heart attack pack in the past, are they optimized and maximized on their beta blocker? That would tell me, okay, they're optimized, and there's probably not much more I can do to make this person's risk any less. So then let's discuss the risks versus benefits. And if the benefits are still gonna outweigh the surgery, and this is where I love the concept of interdisciplinary, multidisciplinary care is, because I wanna have this conversation with the surgeon too, right? I want them to be in as part of this discussion with the patient so then we can all decide together, partnering with the patient is the best move for the patient, and you can proceed to surgery. Now, if they're not medically optimized, that's where I come in, right? I need to make sure that they are on all the right meds, and it may take time for them to become optimized in those. And this is also where I might consider doing some further testing for these patients too as well. So who needs further testing? So for me, when I'm coming to see a patient for cardiac risk assessment or assessment in general, perioperative assessment, if they have an unknown medical history, we've all seen this, right? It's the 65-year-old who's like, I've got no past medical history. Well, when was the last time you saw a doctor? 60 years ago, right? So it's just like, yeah, you probably got some medical history in there. So, we're obviously going to, again, do a great history and figure out, do they have any symptoms of anything that I'm going to be concerned about? Do I think that they actually do have undiagnosed coronary artery disease and they're clearly not optimized for that? Do I think that they potentially have diabetes and they're clearly not going to be optimized for that? I need to look into that further. And again, these are just tiny little things here. But one thing that I do also want to talk about are potentially new murmurs caught on exam, especially in our 75, 80-year-old people with aortic stenosis. I need to catch that before they go to the operating room, or if they're having any other new concerning symptoms. So what tests should we actually consider? So again, all based off of the history and our physical, we might consider doing an echo. We may consider doing a cardiac stress test or a coronary CT. We might consider ordering some cardiac biomarkers prior to the surgery, and that would include our BNP or the NT-proBNP. We may consider getting a baseline EKG, or there's obviously several other tests that we might also consider. So when would I consider ordering an echocardiogram on a patient preoperatively? So if they obviously have any symptoms of heart failure, they have peripheral edema, they have JVD, they're discussing orthopnea or paroxysmal nocturnal dyspnea, they're clearly going to get an echo. If I'm hearing a roaring systolic ejection murmur at the right upper sternal border with radiation to the carotids, they're definitely getting an echo. And really, an echocardiogram could be considered in anybody who has a systolic ejection murmur that is greater than 3 on our grading scale, or if they have any symptoms, or any diastolic murmur. They should all be getting an echocardiogram. These things, though, in general, they don't have to be done routinely. And I know I'm probably contradicting some of the things that you guys are probably seeing in real life, right? I'm sure you're sending these patients for preoperative risk assessment, and they're all getting stress tests, they're all getting echocardiograms, and I'm just telling you that's not evidence-based. So when do we consider stress tests versus coronary CTs? So stress tests are a little controversial right now, in all honesty, because in the past, right, if you ordered a stress test on somebody and it was positive, the next step was guaranteed left heart cath, and they would get some sort of percutaneous intervention if they actually had a significant blockage, or they potentially refer to bypass surgery. What we're finding now is that when it comes to percutaneous intervention, and again, perfect conference for us to discuss here at, stenting is really only efficacious for reducing mortality in somebody having acute coronary syndrome. So if it is just standard CAD with no actual ACS, stenting actually does not help with mortality. It may help with morbidity, but not with mortality. So I would still, though, if I don't know if this patient has a history of coronary artery disease, and that's what I'm looking for, I might order a stress test on a patient to see if they have underlying CAD. I also particularly like coronary CTs, but the caveat with coronary CTs is it has to be done at a center with a radiologist who's very comfortable with reading them, because otherwise the accuracy goes down significantly. But they can essentially be a virtual catheterization. So it can really tell you how diseased those vessels are, whereas with stress tests, even with nuclear imaging, we have a false positive negative rate of about 15%. So the EKG, so when would I order an EKG? First off, baseline EKGs are okay. They're not necessarily that you have to get an EKG in every patient that's going into the operating room. Again, an EKG can be somewhat helpful if they give me history that maybe they had an MI in the past. Again, this is my 65-year-old who's never seen a doctor, but says, oh, once I had that crushing chest pain and I just sort of ignored it. So an EKG is really quick, it's really easy, it's cheap, and I see horrible Q waves suggesting that they've had an infarct in the past. Okay, now I think you may have coronary artery disease. If they're telling me that they have all these palpitations all the time, or when I'm taking their exam and I notice their heart is in an irregular rhythm, I want to know whether or not they have atrial fibrillation. So that would be a reason for me to get an EKG. I do like, as an internist, just have a baseline. I may not act on it at all, like even if there are some abnormalities, I may not act on that EKG, but it's just nice for post-operative that if they develop chest pain or if something else happens post-operatively, I have something to compare it to. So the BNP, so this is kind of a new thing that's coming out, and going back to my friends up in Canada, they have actually been doing this now for years, where for certain patient populations, they will actually go ahead and order a preoperative BNP, and this helps you to predict whether or not a patient may have some myocardial ischemia after a non-cardiac surgery, and that's what that MINS there stands for. The problem with MINS is this is not technically ACS. This is definitely some sort of myocardial ischemia. We know that there's a problem, but we do know that it's a very poor prognostic indicator. So when patients do postoperatively have elevations of their troponin by like 20%, they have a very high risk for actually developing legitimate acute coronary event or even mortality. So it's a prognostic indicator. So in Canada, this has been part of their practice, and now the American Heart Association is starting to discuss this as a possibility of what we're going to start doing routinely. So for patients who are greater than 65 years old and have an RCRI just greater than 1, you would check a pre-op BNP. Or patients who are greater than 45 who have known significant coronary vascular disease, you would check a pre-op BNP. So that is the BNP if it's greater than 98, or if you do an NT-proBNP if it's greater than 300. For those patients post-operatively, you actually want to check post-operative troponins for 48 hours afterwards, just daily, in the morning. They could be totally asymptomatic. And we're just looking at those troponins, and you can even get an EKG to make sure that there's no signs of ischemia. If those troponins do end up elevating, that's when you call your cardiology friends. So that this could be a patient, right, that they may have been as optimized as they possibly could have been prior to the surgery, but they're at risk for developing worsening things. Obviously, if they actually develop a postoperative MI, then clearly the cardiology team will go ahead and do the classic ACS protocol. So other tests to consider, you guys obviously are very familiar with the hemoglobin A1C. Just do keep in mind, though, that I'm sure you guys are well aware of, I've actually been consulted before on the inpatient side where somebody's A1C is 10% and they want to do the surgery next week, and they're like, can you please fix this? And it's like, no, I cannot in a week. I'm sorry. This is going to take a really long time for us to get that A1C where it's at. If somebody is presenting with signs and symptoms of an anemia, so maybe they are having that dyspnea on exertion, but they don't have any orthopnea, they have no peripheral edema, they don't have JVD, but they have pallor, they have decreased capillary refills, check a CBC, because we do want to address anemias prior to the operation. And that is something we do want to try to correct prior to operation. If somebody's been a longstanding smoker and they're audibly wheezing and they've never had PFTs, that's definitely something to also consider to diagnose undiagnosed COPD or emphysema prior to them going to the operating room. Same thing with sleep studies too. So if they're always falling asleep in the middle of the conversation, that's something you should be doing. But none of these necessarily have to be done routinely prior to the surgery. So our final step. So further testing results, if there's no negative new findings, they can go off to surgery. If they do have positive findings, that's where we need to optimize them.